benefit us. As we start this evening, I would like us to just introduce ourselves by dropping your name in the chat room so that we can begin a discussion right there. And as we go on, if you have questions, please put those questions in the chat box as well. We're going to be having a session, a 1 hour session. We don't want to go beyond 1 hour. So the presentation won't last for more than 20 to 30 minutes, and then we'll have your questions. We received a lot of questions during the registration period, and we hope that we'll be able to answer every one of your questions. Before we go on, I want to recognize the presence of the board members, the board of trustees of Lifestyle Champions International. I'm sure they are here in the house. The chairman, Dr. Abel Adigoke, and other members of the board. You're highly welcome. I also want to appreciate all the registered members of LCI, as well as our followers. Thanks for all your feedback on all our social media channels. Thanks for your participation and your contributions. We appreciate you sincerely. So I will go on to introduce our speaker for today. Our speaker for today is on the call. His name is Dr. Shopekhai Itakpe. He's a senior consultant and an orthopedic surgeon at the Orthopedic Hospital, Ibobi, here in Lagos. And he's going to be sharing with us out of his wealth of experience. He manages patients with all sorts of orthopedic problems day in, day out. He frequently has to go to the theater in order to solve many problems. I'm sure he has a lot to share with us. He's a very dear colleague, a trusted friend and colleague, and he's also the executive director of Pouch 98, which is the class I belong to in the University of Ibadan, the class that I graduated from. So thank you so much, Dr. Itakpe, for joining us.
Thank you, thank you. Thank you, Dr. Makinde, for having me this evening. It's a great privilege and pleasure to be here this Friday evening and having so many people gathering here to talk about lifestyle changes and modifications. It's a privilege and an honor to have this conversation. As an orthopedic surgeon, usually you'll be dealing with end products of these disease conditions where you're talking about where arthritis affects the various joints and the surgeries we usually do. But this is something different, talking about prevention, causes and prevention, and how we can mitigate the effect of arthritis. So for me, it's very, very interesting and a very good topic and something we would all learn from. I will be sharing my screen now. Just a minute. Okay. Can we see the screen?
Yes, we can.
Okay, so I'll be talking for over the next 20 or so minutes, and after that, we would have question and answers. The idea is just to give a general overview. This 20 minutes can never be enough in terms of talking about arthritis in its full ramification. It's important to know that research continues with regards to arthritis and how to cure it, because if we can, we'll make old age very bearable for everybody. Because arthritis is something that we all, at one point or the other, will be forced to face. Our objectives this evening will be to understand the disease process, differentiate the varying types of arthritis as possible, identify the known causes, and then discuss the preventive measures that we know. What's arthritis? Essentially, it's a disease of the joint. And so it's a progressive destruction of the joint where pain is the hallmark. You have subsequent loss of joint function. So when you have arthritis, anywhere there's a joint in the body, be it the knee, the hip, the ankle, the elbow, or even the spine, the joints in the spine undergo progressive joint destruction by whatever mechanism or by whatever pathology, and leading to severe pain and loss of joint function. Ultimately, when people have arthritis, they have impaired activities of daily living. So that's when people say that they can't walk the distances that they were used to, or they can't do the things that they could do. They can't sit for long, or they can't stand for long, or they cannot run, or they cannot walk. There's significant effects to the activities of daily living. Discussing the types of arthritis that are available. Classification. The first type will broadly classify into inflammatory and non-inflammatory types. And of the inflammatory type, the commonest is the rheumatoid arthritis. In this environment, we used to say that rheumatoid arthritis is not common, but that's not so true anymore. We're seeing more and more patients with rheumatoid arthritis and the other forms of inflammatory arthritis, SLE, juvenile rheumatoid arthritis, and relapsing polychondritis. And in the image you can see there, you can see rheumatoid arthritis in the late stages, where you see the deformities that you can see in the fingers and the pain in the small joints of the hand. For the non-inflammatory, the most common or the most popular is the osteoarthritis, and that is the form of arthritis that we'll be discussing commonly today, because that's what is the most common form of arthritis known. It's the degenerative joint disease. Other types of non-inflammatory arthritis is neuropathic arthritis, which the Charcot's joints, or the ochronosis. As our society gets wealthier and more people have increased wealth and increased changing eating habits, you then find diseases like the crystal deposition disease, of which the commonest is the gout, where there's increased uric acid level in the system and leading to crystals being deposited around the joints and causing inflammation and joint pain. This is common amongst the middle-aged to elderly with high protein intake. We will not forget the infectious causes of arthritis, of which the ones we worry most is the pyogenic or the septic arthritis that we'll find in children. Then we will not forget tuberculosis as a cause of arthritis in the hip, in the knee, and in the spine. In our environment, we have patients with sickle cell disease and people who have hemophilia, who are bleeding into the joints, leading to arthritis as a result of repeated bleeding in the joints. These are not common events. This pigmented nodular synovitis is a disease pathology that is found in the joints, and we have recurrent bleeding into the joint as well. Hemorrhagic cause of arthritis is not a common thing, and we will not be discussing that with regards to lifestyle changes. Of course, this can also occur in the spine with ankylosing spondylitis and with other joint diseases, with Reiter's disease and psoriatic arthritis. I will focus this evening on osteoarthritis, which is the commonest one, and is the form that occurs as a result of what we will call wear and tear. This has a progressive loss of cartilage structure and function. The cartilage is the covering on the bone in each joint. And as in osteoarthritis, this cartilage structure gradually decays and gradually gets worn off, such that you have bone-on-bone effect and increased pain in that joint. Most forms of osteoarthritis are idiopathic, meaning that we do not know the basis. However, we do know that most of the other forms of arthritis, like that inflammatory arthritis, will ultimately lead to osteoarthritis as a final common pathway. Also, when patients have had infection or have had injuries to the knees or hips or the joints of one form or the other, ultimately the cartilage gets disrupted, and that protective effect of the cartilage is lost and eventually would lead to osteoarthritis. So the myth of the matter is, what are the risk factors to developing osteoarthritis? The first one is to talk about genetic. There's a COL2 defect, which is commoner in females and in males. And we see this when you find out that you have a familial predisposition to osteoarthritis. So you say, oh, my mother had osteoarthritis too. I've had patients who say that, oh, this thing you're talking about, my mom also had it, or my grandmother also had it. So sometimes you have a genetic predisposition to osteoarthritis. Second point is obesity. Where you have increased weight, it leads to increased pressures on the joints. And we know that patients who are overweight and obese have increased risk to various forms of joint degenerative disorders, from the spine to the hip to the knees. Structural abnormalities around the joints, like femoral acetabular impingement in the hip, various forms of bone dysplasias and bone dysplasias around the joint also predisposes to osteoarthritis in any of the joints in question. When you have the K or the bow legs, they lead to a maladjustment in the weight carrying process of the body, such that the weight through the spine to the hips to the knees are not distributed appropriately. This imbalance in weight distribution or force distribution across the joint will lead to osteoarthritis. So patients with increased bow leg or increased K legs are at risk of this problem. Again, when people have had trauma to their knees in the past, either meniscal injuries or ligamentous injuries to the knees, or various injuries to the hips, particularly with sportsmen, they have increased risk of osteoarthritis as they grow older. The diagram here tries to show what the normal knee looks like, normal joint looks like, a synovial joint in particular. And you see the bone there and the cartilage covering over it with the synovial fluid. In osteoarthritis, the cartilage is lost such that you have a bone-to-bone articulation and rubbing together. And then the various bone changes or various changes the body tries to do to adapt to this is what we see in the x-rays and the MRIs. In rheumatoid arthritis, on the other hand, there's no significant cartilage loss, but increased inflammatory response, leading to joint destruction, and eventually at the tail end, the cartilage is lost. What are the signs and symptoms of osteoarthritis? Pain. Everybody knows that when you have osteoarthritis, you will have pain. And as the disease progresses, the pain becomes more and more unbearable, less and less amenable to regular analgesics, and you need more and more analgesia to achieve pain relief for shorter and shorter time. Another thing you will see is stiffness. So people will complain that if they sit for long, for a short while, when they want to get up, the joints are creaky and stiff, and then they start off pain. So they feel pain in the knees, or pain in the hip, or pain in the back when they just want to start moving. Then you notice that the ability to move, the mobility of the patient or the individual decreases over time. And we've seen patients who show up in the hospital who are wheelchair bound simply because they have arthritis. And when they have joint replacement done, they return back to function. Then creaking sounds. People will say, oh, my joints are creaking. I hear that creaking sound. It's just making noise, It's making noise as I walk. I hear the sound. It's just one cartilage with bone-on-bone articulations going on in the various joints. So to the meat of this topic is, what are the causes that we can see that leads us to having arthritis, that can predispose us to arthritis? And we can divide this into two broad groups, the modifiable ones and the non-modifiable ones. And essentially, we know that the modifiable ones are the ones we can actually make lifestyle changes about, that the causes that we are within our control, that we can work with and ensure that either we don't have arthritis, or if arthritis then develops, we can manage the arthritis successfully. The number one in this group is weight. We know that obese patients have increased risk of back pain, hip pain, knee pain. And all of these are as a result of degeneration in the cartilage, as a result of increased load across the joint spaces. And so we know that weight loss alone can significantly reduce the effect of arthritis when it has developed, and can reduce your risk of developing arthritis across any of the joints, particularly in the knees and the back. The second point is that anytime the joint gets infected, remember we mentioned pyogenic or septic arthritis, which is a common thing in childhood. Anytime that joint gets infected, the sequelae or the long-term effect of that is that the cartilage never really fully recovers, and that cartilage gets lost and it develops arthritis subsequently. Therefore, we should take infection in children very seriously. When a child complains about pain around the knee, around the hip, we need to take it seriously. When we see boils around the knees or the hip, swelling around the knee, swelling around the hip, those things should not be taken lightly, because when you have infection in those joints, the long-term sequelae is severe arthritis. The third thing is joint injuries. So people who get fractures around the knee, the hips, the spine, people who do sports who get ligamentous injuries should get adequate treatment. Otherwise, the risk of developing osteoarthritis in later years is significantly increased. Occupation also, occupations that particularly around the knees that involve repeated deep squatting, that's particularly important with sportsmen, will increase the risk of developing arthritis as well. And this, cigarette smoking, we know studies have shown that the rates or the risk of rheumatoid arthritis, as inflammatory arthritis, is higher with people who smoke cigarette than those who do not. And then we also do know that cigarette smoking, with the free radicals that are sent into the body and its effect, we know how we know the effect on the cartilage and deleterious effect on the cartilage, which is the central theme when we're discussing arthritis. For the non-modifiable factors, the first one is age. And like I say to patients, if you live long enough, you will develop osteoarthritis. If you live up to 100, you live up to 120, you will develop osteoarthritis. So with increasing age, you have joint degeneration that will occur. The question is, how do we manage ourselves such that this increasing age does not catch up with us and make us immobile? Second point is that females tend to have an increased risk for osteoarthritis than males, and that is related to the genetic component that I discussed earlier. The other point is that in some groups or in some families, there's a genetic predisposition to developing osteoarthritis. Having known the causes, we can then set out to prevent this, addressing the modifiable causes. because we cannot do anything to our genetics, we cannot do anything about growing old, and we cannot do anything about our gender, but we can do something about our weight. So weight loss is important. It's very important that we keep within the regular BMI of less than 24.9. And a lot of people think that they are not overweight because they don't look so. But during your BMI, you get to know that you're probably overweight or even obese. The next important thing is physical activity. The guidelines say that it is required of us to have 150 minutes of physical activity per week, which can be divided in allocates of 30 minutes every day. And those 30 minutes can be split into 10 minutes at a time and at a stretch. This physical activity should also include muscle strengthening activities. We must know that exercise is not just good for the joints, it's good for the bone. And that the more you exercise as you in your youth, you build bone mass that will stand you in good stead in old age, because as you age, that bone mass decreases and increases your risk of varying types of fractures as a result of osteoporosis. Therefore, physical activity is very, very important for all of us, not just for the joints, but also for our bone mass. The third point is, with regards to physical activity, is the use of aerobics. This also helps to improve balance, as you know, some of the problems with arthritis, particularly with the knee, is the negative feedback to the brain and poor proprioception. So aerobic exercises also helps to improve that. Stop smoking. If you're smoking and you've not smoked, don't start. I get a question every time about exercise. How do we go about with safe exercise? I see patients who come in because they want to start exercise. They're in their 40s, they didn't exercise all through their 20s and 30s, but suddenly they're 40 something, and their blood pressure is up, and Dr. Ria said, go and exercise, and then they become weekend warriors, and then they become my patients because they develop severe knee pain. And what has happened is that they have not had safe exercise. The general tendency with that is that people then withdraw from exercising because they are afraid of the injuries that they have developed, the increased pain in their joints, or the wear and tear that they have. My message today is not to stop exercise, but to have safe exercise. And for us to do that, we need to start slow. Modify activity if when you start, you develop pain. So for example, you start brisk walking and you do 20 minutes and you develop knee pain. Reduce to 10 minutes and build it up again. But whatever you do not stop exercising. Ensure you do joint-friendly activities. There's a bit of controversy here, but my own school of thought is that avoid activities that involve or exercises that involve joint pounding. So it is better to do a brisk walk than to start to go on a heavy jog when you're in your late 40s and 50s if you've not jogged all your life. The risk of meniscal tears and repeated knee problems is increased. And what tends to happen after that is that people then stop exercising altogether and lose the benefit of exercise. Joint-friendly exercises will include brisk walk, swimming, which is the best exercise anybody can do because it exercises the whole body, the back, the hips, the knees, and cycling, which is particularly good for your knees. Recognize safe places and safe ways to be active. I'll also add, use safe gear. So it's like asking people to go jogging on a high wearing heels. Of course, that's looking for trouble. So why would you go jogging and you're not wearing the right footwear? Why would you go jogging on surfaces that put you at risk of having ankle or knee injuries? So you need to know what is safe and where is safe, and also to wear the right equipment so that you do not worsen your situation. And finally, when you start to exercise, it's very important to talk to your doctor, because you need to know about your cardiopulmonary reserve and your cardiac function, because we've heard tales of people who, because they want to get fit, and because they've heard talks like this, start to exercise and do beyond their levels and have sudden cardiac events. We don't want that to occur. Secondly, when you start to exercise, if you then develop increased pain, it would be good to have a word with the orthopedic surgeon or to your sports or to your general physician, so that you can then recognize safe places and safe ways to be active and know how you can modify your activities. In all, you need to stay smart so that you can continue to exercise. My take-home message this evening is that different forms of arthritis are available in the system. We do know that the most common and the most prevalent is the osteoarthritis. Weight loss and exercise is key in prevention, and it's a low-hanging fruit of the modifiable causes of osteoarthritis. Say no to cigarette smoking and engage the relevant health practitioner in your journey to good health. Thanks for listening.
Thank you so much, Dr. Itakpe. That was short but concise, and you touched on very salient points, which I believe have gotten the attention of everyone here this evening. You know, when we advertised this, excuse me, this webinar, quite a number of people sent me messages saying, I have pain in my knees, I have back pain, you know, they wanted treatment. But I've been thinking, how can we even reduce the risk of people developing, you know, this form of arthritis known as osteoarthritis? So it's very clear that we have two forms of arthritis. Someone left a message for me just now asking whether it is the non-inflammatory type of arthritis that can be managed using lifestyle measures. So I think that's one thing that you might have to still put some emphasis on. And I'm really happy about what you talked about on safe exercise, you know, because a lot of people think that they can just get out there and start running or jogging or jumping. Exercise clearance is very, very important, you know, both for the cardiovascular health and also for the joints, just like our speaker has said. So this is a very, very enlightening presentation, and I can see that people are already throwing in messages in the chat room. I want us to know that here we're not going to be talking about treatment, but we want us to be aware of what could have predisposed you to whatever condition you might have, or maybe your relation or friend or colleague, and you would need to assess care in the hospital. But for those of us who don't have any of these symptoms, this is very important for us to know what we can do. So I'm going to start reading out the questions. And please, I want us I want to try and see how I can put together similar questions so that I'm not reading out the same questions, you know, to the speaker. So if you know that your question, the question you have on mind has been noted down, please, you don't need to repeat that. So for the first question, is it just non-inflammatory arthritis that requires lifestyle modification in order to prevent or control the symptoms or the risks? So I think let's start from there, and then I'll scroll through the others.
Yeah, thanks for the question. All forms of arthritis can be managed. So let's put it this way. In all forms of arthritis, the management is a step-ladder approach. And we usually start from the lowest hanging fruits, the lowest rungs, which will be the over-the-counter medications and lifestyle modifications. So for all forms of osteoarthritis, lifestyle medications will be involved. All forms of arthritis, whether it's inflammatory or non-inflammatory, you will have some form of lifestyle modification. It varies from one joint to another, and it varies from one type of arthritis to another. I focused on osteoarthritis because that's something that is really, really common. And the honest truth is that everybody is at risk of osteoarthritis if you live long enough. So really, lifestyle modification is important. It's one of the things you start off with. If you've noticed in this conversation, we did not go into all these other forms of treatment with regards to arthritis. We try as physicians to ensure that these things are the ones you do first. Is when those don't work, or when the disease progression has gone beyond that, that you then go to the higher things and then eventually end up with surgery. And there's so many surgeries that we can discuss, and be here for another 2 to 3 hours talking about it. Okay.
Okay, thank you so much for that clarification. There's a question here. Can high impact exercising like running or jogging cause osteoarthritis?
Okay, that's a very, very good question. I like it because back in the day, we used to say, look, high impact exercise would worsen arthritis. You shouldn't do high impact exercise. But there's a lot more information now and a lot of people are changing their views now. So for the point about arthritis is that the pain you get, particularly with osteoarthritis, is as a result of inflammatory chemicals around the joint, and 2, because there's swelling within the bone. So when you exercise, any form of exercise, it has been discovered that the body, the muscles, the tissues around that joint produces new chemicals that act like analgesics. They counter the inflammatory cytokines, the inflammatory chemicals that are flying around. So it's just the same way you know that if you do an exercise, you get these feel-good hormones with exercise. That same thing goes on with the joint. So you exercise regularly, those chemicals are secreted around it, and they help up to mop up the inflammatory cytokines or chemicals that are there. Secondly, the exercise also helps with the muscle strengthening, and the muscle strengthening has been known to help with relieving the joint pain. So any form of exercise, whether high impact or low impact, is good for the joint. However, because it's still controversial, my own school, or my own view is that rather than do high impact, particularly with knees and spine and things like that, I would modify. Remember we said SMART, modify activity. Do not stop exercise, but modify activity. Particularly is important for those of us who are middle-aged, who are just beginning to start exercise. You didn't exercise the whole of your 20s and 30s, and then you are now just starting exercise. It's not the same. So for those kind of people, I would suggest low impact. Don't go jogging and pounding on the road and damaging your knees further, in quotes. But do a brisk walk, get an exercise bike and cycle. Or if you live in a safe estate, get on a bike and ride around. If you can swim, please do swim. But it has to be a consistent, continuous lifestyle. It's not a start, stop. It's not a one-off. It's a continuous, consistent lifestyle. That is the only way you get the benefits for your joints. So whether it's high impact or low impact, the message is that you must continue to exercise, and you must exercise smart.
Wow. Wow. That's really instructive. We have to be consistent. We shouldn't stop. We should practice safe exercise. Okay, another question here says, what impact does wearing of high heels, especially by ladies, have on developing osteoarthritis or rheumatoid arthritis?
No impact on rheumatoid arthritis, maybe on osteoarthritis, because of biomechanics. So it is not natural for you to walk on your tiptoe continuously for a whole day, because that's essentially what you do when you walk on heels. So you alter the biomechanics. And if you notice, there's a common joke that when females are in their 20s, their heels are like 6 or 7 inches. When they're in their 30s, it becomes like 4 inches. When in their 40s, it becomes block. When in their 50s, they start wearing flats. It's all because of the pain. Nobody tells you the back pain and the knee pain and the risk of the ankle. So really and truly, it's the increased risk of arthritis that it gives you because of the alteration in the biomechanics from the spine to the hips to the knees. It has no effect on rheumatoid or inflammatory arthritis. It's just the degenerative arthritis, which is the osteoarthritis, that it has an effect on.
Okay, I believe that has cleared that question. Someone is saying that she has osteoarthritis and she wants to know what else to do in addition to losing weight. She uses braces, knee braces every day. Is there anything outside what you mentioned before about safe exercise, not smoking, that you think she will
Well,
benefit
I
from?
think from what she's discussed, she really needs to get evaluated because it's difficult to determine what form of arthritis she has. I mean, it sounds like a young person, so we need to find out why and then address the specific problem. So if you've lost weight, braces are not meant to be worn on a permanent basis. So there's something wrong and something needs to be addressed. So she needs to see a physician and get that sorted out.
Okay. So please, that applies to everyone who might be having similar symptoms. Please get evaluated by your physician and possibly a referral to the orthopedic surgeon as well. Someone says, I've heard that taking cold water causes arthritis. How true is this?
That's not true. It's not true. But what typically happens with patients with osteoarthritis is that in cold seasons, in cold weathers, the pain is worse. That's what they will tell you. So if they're abroad in winter, it's terrible. The pain is worse. In Nigeria in the rainy season, in the heat of the height of the rainy season or harmattan, the pain is worse. They will tell you they don't want the ACs on because the pain just gets worse. So it's just that typically the symptoms are worse in cold weather, not that cold water has no effect on osteoarthritis.
Okay. Thanks for clearing that fallacy because we have a lot of them out there. And I want to try and combine about 2 or 3 questions because they're similar. Someone wants to ask if skipping is safe for the knees, especially having 1,000 skips 3 to 4 times per week. And then someone says, I don't want to have a bent knee. That's my worry. I don't want my knee to bend. I don't know the background for that. I don't know what is causing the fear. You might need to want to follow up that with an explanation. And then one person is saying, my ankle is prone to injury following an ankle injury I had when I was younger. It throbs every night. I can't sleep. Can this be permanently cured?
Okay, so I'll start with the ankle. The ankle needs to be evaluated. So it's probably there's some cartilage damage around the ankle from the previous injury. There are various things we can do to address that problem. So there can be a solution to that. You need to get to see the orthopedic surgeon to address that. With regards to skipping, again, I'll go back to my SMART. If you are doing 1,000 skips and you do not have any deleterious effect, please, by all means, continue skipping. Continue to do your exercises. It's okay. If, however, you have knee pain following skipping 1,000, then you need to have to modify that. So that's just basically my own take regards to that. There was a third question. It skips me now.
Yes, someone wondering whether her knee can heal since she had an ankle injury as a child, and the same ankle is still prone to injury. Sorry, ankle.
I've addressed the ankle.
Okay.
There's something about bending knee.
Okay, bending.
She doesn't want her knee to bend or something.
Yes, but that's not really clear. I think we might need a follow-up question to that.
Okay.
We've already answered the question about the relationship of cold environment and arthritis.
Yes.
Well, I'm getting some questions about bitter cola, whether it has a positive management in osteoarthritis, whether it can be used.
I don't know anything about bitter cola, but what I suspect with bitter cola is that it probably has some analgesic effect, which is probably what happens. I mean, I can tell a story. I mean, this is a true life story. Some patient I had way back who had severe back pain and who were being worked up for some injection, and he missed it by something. I can't remember why. And then shows up 2 weeks later and comes to tell me that, oh, well, he didn't come, but he went to take some herbal one thing, and his pain is gone. I mean, you can't argue against someone who says his pain is gone. So really, that happens. But the truth of the matter is that it's likely that whatever is in bitter cola is some analgesic effect. I don't know about it. It doesn't change the pictures when you do the x-rays several times. It's still the same. So it's probably just a very strong analgesic effect within in the bitter cola.
Okay, how well do the glucosamine conjoined supplements help to regenerate the lost cartilage in osteoarthritis?
That is a very controversial. It's a very controversial question. It's controversial and it's commercial. The truth of the matter is that the oral supplements cannot go and do anything for the joints. It's not, studies over and over again have shown that they're not better than placebo. So really and truly, oral glucosamine and and the various versions don't do anything. However, the intra-articular, that is injections into the joints with hyaluronic acid and co, have some benefits. Again, that's not fully proven how much effect it has, but there's still some benefits with the joint injections with the supplements. But oral intake, take one a day for 1 million years, the arthritis will just continue to progress. It doesn't do anything.
Okay. Thank you so much for that. We have one of members of the Board of Trustees, Mrs. Grace Adegoke, raising her hand. I think she wants to either contribute or ask something. So I will just allow her to unmute herself to also add to the conversation.
Hey, good evening, everyone. Thank you for having us on tonight's beautiful presentation. So thank you very much. Can you hear me? Is it clear enough?
Loud and clear, ma.
Oh, good, good. So I just want to share a few tips. The bottom line is I want to make myself a little bit vulnerable here because I actually had arthritis on my right knee. I mean, I know for many, many years, this has run in my family. You know, a few people younger than myself, they've had the arthritis. And when I got this, I was in the middle of a Tai Chi class, you know, so I just stooped down as you do in Tai Chi and I couldn't come back up. So I struggled and I came back up all by myself without asking for help. So from there, that same day, I tore my ligament on my right knee. And from there on, it was like, you know, going down. and the arthritis kicked in. Of course, I had a repair done on the ligaments, and then subsequently, the arthritis just went out of nowhere to grade 4, which was the last stage. And I was booked for a knee replacement. I wasn't 50 then, I'm now 50 plus, you know. So, but already I was taking some collagen, as you do as a woman, for some other reasons. And then I read a research in America about a doctor who had his clients taking collagen, you know, regularly, and by the end of the second, third month, they were all counseling their knee surgery and stuff like that. So I already had collagen in my cupboard. So I started taking it, and you know, I've got this. This is multi-collagen. This is bovine, and I've got another one. I've got it in tablet form. Well, I'm a woman of faith, and I want to say, with prayer as well and everything else I'm doing, I just declined. I canceled the operation because I got better than I ever was. In fact, that arthritis was affecting my quality of life. And we have maintenance, treatments, steroid injection. It wear off after a couple of months. I'll go back. And the orthopedic surgeon is very kind and everything. And it shows on the x-ray. But now, this is the 3rd year. I'm fine in the sense that, I mean, I still have pain every now and then, but not to the extent of what I had. So I just want to share that with you if you're going through anything like that. And what the collagen does, it helps to build your muscles in the same way that the exercise, weight-bearing exercise, will build your muscles, your quads, especially if you have problem on your knee. If your muscles are strong, you got better structure holding your joints together. You see, the thing with the muscles, if you don't use it, you lose it. That's the slogan for the muscles. So if you're not doing exercise, your muscles are wasting away. So you have less support structures around your joints. So that's number one. And as you probably guessed, I'm a perimenopausal woman. So for women, as we advance in age, all of your hormones begin to dry up, and that has effect on drying up your joint as well. The lubrication is less than it used to be. So if your structures are drying up, and you know your cartilages, if your cartilage is dry, like if you leave a piece of cartilage on the table, it begins to dry up if it's not in liquid. So the same thing for perimenopausal women or menopausal women, your cartilage dries up and it's easy for them to snap, which is a prerequisite for arthritis at that age. So weight-bearing exercise, like the speaker said, in your 20s, as a teenager, that's when you need to cultivate the habits of fitness. And I'm lucky because I was already a fitness fanatic before all of this happened. And I found my way back into adjusting what type of fitness I can do. Walking half an hour, yoga stretches, as it's been mentioned, some Pilates, but not with the difficult technicality and stuff like that. So build your muscles and do a few other things. But the main thing I also recognize is if your feet is flat, if you're flat-footed, you know, if you don't have a particular arch on your foot, Yoruba will say, Odesedele. You know, if Yoruba speakers are on this Zoom tonight, if you are flat-footed, you need to check that out. You might need a support, you know, to raise your arch up, to create a fourth arch, because that in itself will have a bearing on your joint. When you're walking like this, you literally don't have good support. So a physiotherapist will assess you, they send you to orthotics, and they give you an insole and things like that. And that may just correct some slight pain that are not necessarily arthritic already. So as they say, it's teaching time saves 9. So most importantly, your nutrition, apart from collagen, your vitamin D, your calcium, phosphorus, all of these bone strengthening nutrients on daily basis in whatever we eat. Well, thank you.
Thank you, Ma. Dr. Itakpe, do you want to make any response to the comment on collagen? You know,
well, actually, not even to the collagen. I actually was quite impressed about the issues about the flat foot. That's actually very technical. I'm quite impressed. Thank you very much, man, for that contribution, because it's biomechanics. A lot of this is biomechanics. So if you have flat foot, or like she described, the axis all the way down is affected, and then you then find people who have that miserable malalignment syndrome. So just simple little things like medial insole can actually help to realign that and improve the weight bearing at the knees. Knees are very particularly sensitive to weight bearing. The other thing about it is that she also probably explained better with regards to what I was talking about, exercise, the two factors of the counter chemicals that act against the inflammatory chemicals, as well as the muscle strengthening that's important. Those are the two factors that help with regards to how exercise improves arthritis or even prevents arthritis. Regards to the collagen, again, I can't argue against the personal experience. I never do. This life is it's much more complex than people say. I gave me a story about a patient who used herbs. I'm a doctor. I don't believe in anything he says, but I cannot counter his testimony. So I can only put it on my scientific mind to say, okay, maybe it was this, maybe it was that. So I don't have any. If it's worked for her, it's fantastic. But I guess also she also added other things. I'm happy she didn't say all the pain disappeared. But yes, she has occasional pain, but it is very, very bearable, which is one of the things that I say when I meet people who come for knee, that look, if I tell them I'm going to take away all of your pain with all of these modalities, I'm lying to you, because I can't. We can bring it down to bearable levels, to things that will allow you to function, to stop affecting the activities of daily living. And that's very, very important. If someone who could not walk before, or like she says, having to have constant doctor's visits, that it affects your life, having to go to the hospital, time off work, all of that, and you're not doing that anymore. That's significant. That is certainly significant. So I can't argue against that. What I would always talk about is what the large studies mention and big studies mention. Again, who knows? In another 5 years, maybe that's what will be in the studies that I will come, and if I give this talk in 5 years' time, I'll be telling you, okay, you need to add collagen to your medications. But as of today, I don't know. But again, as I said, never ever argue against personal experience, because if it works, then probably is doing something good.
Thank you for that. We're rounding up gradually. So there's a follow-up to the question about the bending knees or the bent knees. So he's saying, what I'm trying to say is that most people with arthritis always have bent knees. If you see my mom, her situation is very bad with a bad knee that she cannot walk again. I don't pray mine gets that extent.
All right, so I've seen it. I'm reading what he says, and what he's describing is the natural progression of osteoarthritis in the knee. Starts with pain, then over time, pain, stiffness, and over time, you now start having deformities. What is commoner is the bow leg, which continuously gets bowed and bowed and bowed. Occasionally, you have the K leg, which just progressively gets worse. The truth of the matter is that once it gets to that deformity stage, basically the only treatment is surgery, really. You can manage with a lot of other things, but in my books, only treatment at that stage is a joint replacement, because you need to correct the alignment as well as replace the damaged cartilage. Okay, so that's the way that goes. So for us who don't have that deformity already, we are going to try and prevent it by doing all the things we have said. But if in the event of having done our best, you still develop arthritis, the natural progression of arthritis, especially the end stage, is that there's a deformity at the joints.
Thank you so much for that. I'm sure you've read some of the other questions. Someone says, I have left-sided pain, especially shoulder, but also left waist pain and thigh. Initially, I noticed I was sleeping on that side mostly and got better after resting that side for a while. But pain persists, more noticeable in the last 2 months. Ideal BMI, not hypertensive, no palpitations. Could this be arthritis?
Yes, it could be. It needs to be evaluated. It could be arthritis in the shoulder. Anywhere there's a joint, you can have arthritis.
Okay. All right. So evaluation is very important here. We don't really want self-diagnosis, and we can't make a final diagnosis, or what we call a provisional diagnosis here on the call. So it's still to raise our awareness and to let us know that we need to visit our medical practitioner for a proper evaluation. I can see that some
sorry,
people...
Doctor, just one I saw a question here about lots of people with arthritis take prednisolone. What do you say to this? I need to mention this because as an orthopedic surgeon, I get to see the effects of steroids. Steroids can be used very judiciously, very good thing, but they also have their significant side effects. Prednisolone is only useful in inflammatory arthritis. And even for us as orthopedic surgeons, when you see patients with inflammatory arthritis, send them to doctors who manage those. They are called rheumatologists. So they're the ones who will know how much steroid and all of those things that you give. But when you have patients who have knee pain, hip pain, back pain, and then you then give steroids, you put the patient at risk of all the side effects of steroids. And prednisolone does not treat osteoarthritis. So if a patient has osteoarthritis of the knee, giving prednisolone is not the treatment. And we need to disabuse our minds, because what tends to happen is that the patient initially gets better, but then all the other effects of steroids, the osteonecrosis to the head of the femur, the weight gain, the skin abnormalities and all of that. So it's very, very, very important that we know that oral prednisolone is not what to use. We also do something in treatment, but that's not what we're discussing in this webinar, that sometimes we inject steroids into the knee to give relief for a while. It's just for a short while, particularly for people who have very severe pain. Yes, to give them some relief. Yes, you will do that. But that's not the same thing as giving oral steroids on a day-to-day. That's meant for inflammatory arthritis and should be given only by a qualified practitioner who has understanding of rheumatoid arthritis and other inflammatory arthritis.
Thanks for that. A question hasn't been answered. How helpful is the use of braces in the management of arthritis? Secondly, how safe is the jaw massage? I've never heard of that before.
I actually heard one today. So a patient came to me today and says, oh, she has some form of arthritis. I offered her a procedure, and she says after the procedure, can she go to the jaw to continue the massage, because they are very good at the massage. Okay. And then this is inside the clinic in Igbobi. So I'm like, okay, so you're coming to the hospital, but you also want to go to the jaw massage. It's a bit of a conflict in my head. The truth of the matter is that braces are useful for short term. So if you have pain, severe pain, knee swelling, you need to rest it. You use the braces. But continuous use of the braces means that you act against your muscles. So the muscles get weak, and you want to strengthen the muscles around the joint. So we do not advocate braces as a long-term use. Use braces, you have pain, acute pain, short term, 1 week, 2 weeks, but you need to get off braces and need to get into muscle strengthening, regardless of the joint involved. With regards to the jaw massage, again, I don't have competence in that matter. All I know is that I have not seen it work, but people know, well, fine. I haven't seen it work. I don't think it does. But massage in general is useful in improving blood circulation around the joint, and that can help relieve pain. So you do not need to go to your job to get a massage to get some pain relief.
Thank you for that. Someone says, whenever I stop taking glucosamine and conjoined, my knee joints click with every movement. When I start taking them again, the clicking stops. Also with MSM and hyaluronic acid. I guess that goes along with what you said, a personal testimony. We can't counter it.
Yeah. Exactly. I can't counter it, but large studies say it's placebo. But if you take it and you feel better, I mean, it's your knees, your joints. I mean, you're better. So fantastic.
Yeah. I'm in my 3rd trimester and my osteoarthritis has gotten worse. Apart from walking, what other exercises can I do? Can it be totally eradicated?
So, well, 3rd trimester is one of those things. The pregnancy alters biomechanics. Commonest thing people talk about is back pain, waist pain, you know. So I reckon that once delivery, you would be able to get biomechanics back and you should get back in place. It's difficult to even use analgesia at 3rd trimester because of drugs crossing the placenta. I'll just suggest again, continue the walks. The massage is good. There are topical NSAIDs that can be massaged around the joints. That's all useful. Warm compresses are useful too because they also improve the blood supply around them. But I believe that once you have the delivery, that biomechanic alteration goes and you should be able to return back to normal.
Thank you so much. I think those are all the questions we have. I don't know if there are any last minute questions before we call it a day. I have more of a personal question here asking how one can locate our speaker and how much for a knee replacement they're planning to take their mom for operation. I think you should get in touch with me. Just send me a mail. Send me a mail at info@lifestylechamps.com so that we can appropriately refer you. And if you want to receive updates from Lifestyle Champions International, please just leave your email in the chat room before you go. Yes, thank you, Ore, for typing in the email address in the chat box. One more question. I think this should be our last question. Any other thing should be sent to my email. And okay, I'll just put these 2 questions together. If an 11-year-old child keeps complaining of ankle pain intermittently, what does that signify? Please, what is the role of calcium in arthritis treatment? I think you mentioned something about juvenile arthritis at some point.
Yes, so you need to evaluate the child. So is it both joints, and is it associated fever? Are there pains in other joints? So you just need to be evaluated. It might not mean much, but it might mean something. We should not just disregard that. Calcium has no role with osteoarthritis. It has role with osteoporosis. And again, with osteoporosis, this is my opportunity to just talk about it, that you need to build your bone mass before you're 50. In fact, before you're 45. And one way to build your bone mass is exercise, because after that is downhill thereafter, particularly with females postmenopausal, the estrogen supply reduces, and so bone loss increases. And we know that the fractures that occur, back fractures with back pain, hip fractures particularly, are markers of mortality. So you see a patient in 70s who has a fractured hip, usually 20% of them will not see the next birthday. So it's very important. Some of these things look very simple and small or seemingly irrelevant, but the effect in old age is very, very significant. So we need to keep exercising. It's good to take calcium, but I think that if you're exercising and you're having a regular diet, you don't really require the supplements in this age group. Probably in the elderly, yes, they will need supplements. But with regards to arthritis, no, calcium has no role.
Thanks so much for that clarification. So we're going to round off now. I want to remind us that one of the reasons why Lifestyle Champions International is here is because we want to encourage healthy lifestyle choices among like-minded individuals so that we can improve our quality of life, our health-related quality of life, and reduce the risk of lifestyle-related diseases. Not all illnesses are lifestyle related, but several are. So if there's something that you can do about it, then why not? Just like Dr. Itakpe has said, obesity is one of the things that predisposes to osteoarthritis, and osteoarthritis is the most common form of arthritis. So if you know that obesity has a large role to play in developing it, then we should take steps to prevent obesity. And if at all we're already obese, then we can work on our weight. But it's very important that we practice safe exercise. And there are so many other factors too that contribute to weight gain, which we're not talking about here today, that have to do with our nutrition. So that's where we're going to end this evening. I want to thank everyone for your keen attention. Thanks for staying till the end of the webinar. And a special thanks to our guest speaker, Dr. Itakpe. Thank you so much for being here and for patiently taking our questions. We have a lot of thank yous in the chat box. Thanking you for the presentation.
Thanks for having me, man. It's my privilege to be here.
Thank you. So the webinar has been recorded for anyone who joined late. I could see some persons asking you to summarize. Well, you know, we've covered so much, we can't go back now. So we're going to share the video on our YouTube channel so that anyone who missed it can catch up. So thanks once again.
Thank you. And have a great weekend.
Thank you too.
Bye.
Bye. Choose life, everyone. Bye.
Thank you. Bye.
Bye.
Thank you. Bye.
Thank you so much.
Thank you very much. Have a blessed day.
Thank you so much. Thanks for being here. God bless you. Real good.
God bless you.
Dr.
Thank you so much.
Thank you. Thanks a lot. Thanks a lot. I really appreciate yours. Thank you.
Thank you for coming
to our life.
Thank you.
You're welcome, sir.
Thank you.
Thank you, Sister O. Thank you.
You're highly welcome. Thanks for logging in.
Thank you, Dr. Makinde.
Mr. Jaja, you're welcome. Thank you for logging in. So please, for those of